So our first speaker for this session, which is Transforming Social Life in Pandemic Times, is Kiran Pienaar and colleagues. So Kiran's presentation is Making Publics in the Pandemic, the Governance of Care and Intimacy in Australia's COVID-19 Response. Thanks.
Thanks, Anthony. I'm really pleased to kick off this session today, and what an act to follow. Thank you, Simone, that was terrific. And my presentation is actually based on a paper which is published in the special issue that Simone mentioned, and I really encourage you to check it out if you haven't already. So a second plug for that excellent special issue. It's co-edited by Simone and Kim McLeod. And I'd like to start by just acknowledging my co-authors on this piece, Jacinth Floor, who you've just heard from and chaired Simone's session, Jennifer Power and Dean Murphy. And anyone who's interested in accessing the paper, please do get in touch. I'm very happy to share a copy. So I almost feel as though this needs no introduction, but I will just give a very brief account of the COVID pandemic in Victoria. Until recently, which is the focus of this paper, I should add, until recently, the impacts of COVID have been disproportionately felt in the state of Victoria, which has accounted for over 2/3 of the cases, despite representing only around 1/4 of Australia's overall population. This paper focuses on the COVID situation last year, but we acknowledge that it's unfolding and much has changed since then. It almost feels obsolete to be talking about this paper, presenting this paper now, given that the terrain has shifted so much with vaccines now being widely available. But nonetheless, looking at last year, as other Australian states and territories returned to normal activities with some restrictions in mid-May, Victoria experienced a rapid rise in COVID cases in June. As a result, tight restrictions were introduced, targeting various hotspots in Victoria. Despite these measures, infection rates continued to rise, and in early August 2020, the Victorian Premier imposed a lockdown on affected areas. These included a nightly curfew for 6 weeks, a 5-kilometre radius limit on movement, which I should note echoed the current or the situation in Victoria and indeed New South Wales, with both states in extended lockdowns until very recently. So for our purposes, the restrictions rely on a number of normative assumptions. And in this paper, we focus on uncovering these assumptions. In particular, we ask 3 key questions. Who is the imagined subject of public health advice in pandemic times? What are the normative assumptions about viral containment, intimacy, and private domestic space? And who is excluded or rendered a risky disease vector by these assumptions? In addressing these questions, we build on research that has explored the social dimensions of the pandemic and its impact on marginalized groups. And I don't have time to go through all of the literature on which we drew, but I do want to single out the work of Chase Ledden and Ben Wheel on the idealization of quarantine as the end of HIV. This is a great article. It has a similar focus to ours, except applied to HIV. I did discover it after this paper was published, but it's certainly one which has resonances with our work. But with the exception of pieces like Ledden and Wheels, empirical research to date has, to our knowledge, yet to examine the assumptions underpinning COVID restrictions and their implications for marginalized groups. And this is the focus of our analysis. In particular, we're interested in the kinds of public health subjects imagined by COVID restrictions. Our analysis is informed by Michael Warner's influential account of the production of publics, which probably needs very little introduction to most, if not all of you here. So just very briefly, according to Warner, public discourse does not simply address a pre-existing public, but calls particular publics into being. Crucial here is the performative role of discourse in giving publics a particular shape and character. Especially relevant to our work is the concept of counter-public health, first proposed by Kane Race in 2009. This notion critiques moralized concepts of health and examines how, and I quote, political investment in a particular idea of public membership thwarts rational responses to public health, end quote. Applying these ideas to COVID restrictions, we consider the publics they produce and their role in reinforcing inequalities. So a brief note on our methods. Our analysis draws on COVID-related public health advice, commentary, and news media articles published between the 1st of March and the 26th of October 2020. Of course, this coincides with the first and second waves of the pandemic in Australia, with the 26th of October marking the lifting of stage 4 restrictions in Metro Melbourne, at least the lifting last year. In our analysis, we focus on 3 key themes, and I'll go through these shortly. The first is the directive to stay home, stay safe. I'm sure it's a refrain that is very well familiar to all of you. The governance of sex, intimacy, and social connection, and community resistance, and the emergence of what we call queer counter-publics. So starting with the directive to stay home, stay safe. At the centre of the Victorian government's COVID response is the directive to stay home, stay safe, followed by the slogan, "We're all in this together," which continues to echo in government messaging. This message was delivered in sombre tones by government officials, such as the Victorian Premier, Daniel Andrews. As he stressed, saving lives is everyone's job. This is about all of us. And unless you want to be burying an elderly relative or your best mate or your parents, then do the right thing. It's very, very simple. Stay at home. While these messages emphasize solidarity, they contain a number of assumptions that warrant scrutiny. As we know, home is neither equally accessible nor a safe space for many, including those experiencing domestic or family violence, for many queer people, and those who are homeless or sleeping rough. In short, staying home is not as simple as government officials claim. So while we recognise the importance of isolation measures and increasingly vaccination to contain the spread of the virus, we follow the lead of feminist and queer scholars in highlighting the assumptions built into official pandemic responses. And I did note earlier that Sophie Lewis was present as one of the attendees, and we've certainly drawn on your work, Sophie. Made in the name of public health, these injunctions naturalise the home as an apolitical place of refuge and safety. In the process, they efface the constitutive exclusions of the dominant health public. We would do well to ask, how do you stay at home when you're homeless? Or where do you go when home is not safe? We suggest that uncritical acceptance of stay-at-home directives reinforces the myth of home as haven, effacing the gender, racialized, and class structures that shape access to a safe private home. The impact of restrictions on vulnerable communities was perhaps most strikingly shown in the Victorian government's response to outbreaks in several Melbourne public housing complexes. With little warning, Victorian authorities locked down the housing blocks, and residents were subjected to a heavy police presence and severe restrictions not imposed in outbreaks in more affluent areas. Many public housing residents are from low socioeconomic and migrant backgrounds, and the restrictions drew criticism for stigmatizing already vulnerable communities. Some residents commented that the strict lockdown made them feel like criminals and entrenched the existing vulnerabilities of lower income groups and ethnic minorities. This has also played out in similar ways in Sydney, with poorer areas being subject to tougher restrictions due to bigger COVID outbreaks in those areas. So the response to the COVID outbreak in Melbourne's public housing blocks also points to the ideal home that is enacted in public health discourse. A large suburban home with multiple bedrooms and outdoor space, not a public high-rise apartment in the inner city. By extension, the ideal household is assumed to comprise a nuclear family, with each member having their own bedroom. Households consisting of multiple generations and or extended family, living in a small overcrowded space and sharing facilities is the antithesis of the normative Australian household assumed in COVID restrictions. As the government's response to the outbreak in public housing shows, such households are seen as a risk to public health. The idealized notion of home and family underpinning public health discourses suggests a need to critically examine the logic governing pandemic responses, and in particular, what is elided by blithe expressions claiming we're all in this together. We argue that public health measures are performative in that they produce stratified health publics, entrenching the privilege of some groups and disadvantaging others. As mentioned earlier, the Victorian State Government's response comprised restrictions on social interactions, which we're all very familiar with in Victoria and New South Wales. While non-cohabiting couples were able to visit each other, single people living alone could not visit friends or family. By allowing visits between intimate partners on the grounds that they constitute modes of care and support, Australia's COVID restrictions implicitly renounced other kinds of care, including those associated with queer forms of kinship, close friendships, and casual sexual practices. Indeed, mention of sex was conspicuously absent in official discourses, and I know a number of other Australian sociologists have remarked on this. And this was despite the implications of restrictions for physical touch and intimacy. In addition to omitting any reference to sex and intimacy, Australia's restrictions produced a hegemonic public normatively defined as consisting of middle-class nuclear families. In official discourses, this intimate public, and we're drawing here on the work of Berlant, is legitimized as necessary to contain the spread of the virus and to save lives. This appeal to saving lives works here as a powerful authorizing move that obscures the social norms informing public health practices. It inoculates public health practices from critique, rendering them self-evidently good. It's quite hard, in other words, to argue with the appeal to save lives.
Just 3 minutes, Kiran.
Thanks, Anthony. While government responses overlooked care practices beyond the hetero or homonormative nuclear family, Australian community and sexual health bodies addressed them explicitly by considering the implications of physical distancing measures for sex, intimacy, and connection. For example, Victorian LGBTQ organisation Thorn Harbour Health offered pragmatic advice on casual sex during the pandemic, and I've included it here. If you and a regular casual partner, aka a fuck buddy, are both practicing physical distancing from others, you can have sex with one another with a low risk of acquiring COVID. However, communication is key. You need to have a clear and honest conversation about what exposure each of you has to others at this time. You also need to let each other know immediately if either of you becomes unwell. These responses, we suggest, are informed by the legacy of HIV activism in response to mainstream HIV responses, which often sought to shut down discourses of sex and pleasure, placing abstinence or monogamy at the center of prevention messages. In contrast, queer community responses foregrounded fun, pleasure, and eroticism, creating counter-public health discourses. This was not done to transgress normative public health discourses, but rather as part of an ethic of care that brings ideas about safe sex into sexual practices and cultures. These examples suggest that those excluded from the dominant public health are finding innovative ways of creating more inclusive forms of care and connection, extending Berlant's concept of intimate publics. We refer to these alternative care networks as intimate counterpublics. Inspired by their inclusive ethos, we argue for the need for more inclusive modes of care, or to foster more inclusive modes of care. Doing so entails the development of public health approaches responsive to the needs of diverse publics, including intimate counterpublics. As we've seen, these diverse publics include homeless people, survivors of domestic violence, and those in non-traditional households, such as blended families, queer chosen families, and single people living alone. Therefore, we need models of care that extend beyond the nuclear family, challenging its status as the normative social unit. As Tickton notes, and I quote, "COVID has generated the need for new relationships with friends, comrades, neighbours, co-parents, lovers, and ex-lovers. Relationships that require deeper trust and sharing in new respectful ways that limit exposure to risk while still enabling sociality." And here are a list of the key references I've drawn on. Thank you all for listening, and to my fellow co-conveners for the opportunity to present. If you'd like to find out more about the paper or have any questions, I've included my contact details there. Hopefully I was on time, Anthony.
Thanks so much, Kiran. Yeah, absolutely. We've just got a couple of minutes. I'll just see if there's any hands popping up. If there isn't, I've got a question. I don't think I can see any hands. So my question, I guess, sort of troubling the public health subject. But I'm also curious, as part of this research, were you and your co-authors also thinking about the institution of public health? Because I think during COVID, we've often talked about public health as just one thing, you know, and it's a set of practices, it's a discipline, it's a set of institutions and departments. So yeah, and how would that relate to then constituting the subject?
Thanks, Anthony. That's a great question. So I think certainly we are interested in troubling the institution of public health, but it wasn't a kind of central focus. We were more interested in how appeals to a kind of dominant health public constitute subjects in particular exclusionary ways. But as part of that, acknowledging that the practices and institutions of public health are generative and constitutive. So I guess we would say, and speaking on behalf of all my co-authors, that they're co-constituted and entangled. But in terms of our kind of heuristics and our analytic focus, we were more interested in the kinds of subjects that they imagine, and also in relation to the lockdown in Melbourne public housing, the kinds of homes that are imagined and who's excluded, the kind of home and family. So that was, I guess, the agential cut that we made in our analysis to focus on subjects, home, and questions of care and intimacy. But there's definitely a space for work querying and thinking through and critiquing the institution of public health. So yeah, thank you, great question.
Thanks. We've got two hands up. So Karen, I think, is first.
Kiran, thank you so much. I really enjoyed that that presentation, and I love your work so much anyway. And I love the notion of counter-public health as well. But I had I guess more of a practical question. Like the framing of everything is so beautifully done, and it makes so much sense that these public health directives have an imagined kind of subject, home, you know, space, all that sort of thing. But just thinking about the sort of disparate policing of those directives, though, I don't know whether in Melbourne it's been as stark as it has been here in Sydney. And I'm just thinking about the sort of the notion of queer counterpublics as they're practiced with people who have less social capital, indeed lower socioeconomic, you know, kind of capacity, even people experiencing homelessness, for example, where the resistance into creating a form of an intimate counter-public is practiced and responded to by law enforcement. You know, so having like a nice queer kind of sex, casual sex kind of, well, temporarily monogamous casual sex with queer friends, on one hand, I think is a bit more achievable than the types of, you know, the resistance, but even the police presence for, you know, the lockdown towers, which we also saw in Sydney with Mission Australia's Common Ground as well.
Yes, absolutely. Yeah. So, and I think that these forms of resistance, I should add, and I think you've raised an important point, Karen, they do actually rely, as you say, on a lot of social capital, and they're easier for some groups to mobilize than others. Certainly gay cis men, if I can generalize from their history of HIV activism, they are a kind of a well-constituted collective. They're very good at advocating, and other marginalized groups might not have that social capital. And of course, a police presence, for example, in the public housing towers, as that demonstrated, those migrant groups might not have recourse to the same kinds of legal and social capital that would make their activist efforts effective and enable them to form sites of collective resistance. So I think you're right. I wouldn't want to kind of gloss over those differences and the important role of inequalities and power dynamics and access to social capital in enabling resistance. I hope that gets to your point.
Absolutely. I just think that obviously there needs to be more support for those less privileged people, I think, in order to build that collective resistance. Otherwise, it just looks like individuals running amok and, you know, and being bad citizens.
Yes, exactly. Exactly.
Great. So we'll just have to end there. I know there's another question, but we're going to have to move on to the next talk. Thanks so much, Kiran.